Mm, hands do more than wave, 'cause it can kill and they can save. You, you are the key. Let's sing your hands, so sing with me. You are the key. Let's sing your hands, so sing with me. Hands are such a simple thing, but our hands can change most everything. Keep care safe, give life a chance. Be careful, it's in your hands. Hands are such a simple the fight. Do nothing care. It is your right. Hands are such a simple thing, but our hands can change most everything. Keep care safe, give life a chance. Take care for all that's in your hands. Hands are such a simple thing, but our hands can change most everything. Keep care safe and take a stand. Keep care for all that's in your hands. All around the world.
All around the world.
Let's join our hands.
Let's join our hands
Be heard.
and let's be heard.
Rub your hands for you.
Rub your hands for
For
you,
those you love.
for those you love,
And patience too.
and patience too.
All around the world. Let's rub our hands and let's be heard. Hands are such a simple thing, but our hands can change most everything. Keep care safe, give life a chance. Keep care for all that's in your hands. Hands are such a simple thing, but our hands can change most everything. Keep care safe and take a stand. Keep care for all that's in your hands. It's in your hands. It's in your.
Oh, that is the official song for World Hand Hygiene Day. So, welcome to class. This is Infection, and my name is Kim Uddo, and we're going to get going. I think that everyone has a handout. I don't know if y'all print handouts anymore. If you don't, pull it up in a new tab or so you can refer to it during our class today. And I'm going to share my screen. I guess I'll hit the record button again. So welcome to Infection, and the exemplar is sepsis. Am I recording? Hang on one more time. Record. Sorry.
Recording in progress.
Great. So we're recording, and we are going to talk about infection. And the exemplar is sepsis, septic shock, and DIC. So you should be able to see my screen, and this is just our web page where you got our Zoom link from. And unfortunately, I got an email this semester saying that the 3-hour sepsis class has been reduced to 2 hours. So for this semester, due to calendar reasons or whatever reasons there were, it was reduced to only 2 hours. So I had old recordings on our webpage from last year. So if you were going, why is this is a 2-hour class, but I'm listening to 3 hours of lecture? Because it's supposed to be a 3-hour lecture, but this year it's a 2-hour lecture. So you're only going to get 2 hours worth of test questions. So the test questions have been reduced in this content. Okay, so y'all should see my PowerPoint slides. And sepsis is a huge world crisis. And this slide is already old. We used to be concerned about 9 million to 9 million deaths globally every year. And now that number's up to 11 million. And the 27 million to 30 million have sepsis, and 11 million will die. So, and if you do survive sepsis, there's going to be consequences. Sepsis knows no income bracket. It gets us all. This is a picture of one of the famous people, Muhammad Ali, who I knew in 6th grade as Cassius Clay, but he died of sepsis. And this is what the people in septic shock look like. You've all been to ICU and you've seen this. They're hypoperfusion to the brain, so they're unconscious. They can't breathe. They can't ventilate. They can't diffuse. So we have them on the ventilator. We may have them on renal replacement therapy. So this is where they end up in septic shock in the intensive care unit. Now, you don't have to be famous. You can be the girl next door, like Cassidy Pressenbach. She graduated from Charity School of Nursing. She was a nurse. She, after her third child, had decided she was going to have an IUD placed and developed toxic shock and sepsis, and was a septic patient in ICU. And she is a brave, a fearless sepsis survivor. But one of the complications is amputation. It's hypoperfusion to the extremities from the sepsis, as well as hypoperfusion from the toxic vasoconstrictors that we use trying to get blood flow to the vital organs. Will take the blood flow away, or will clamp down on the peripheral hands and feet. So sepsis, cognitive. So up to 60% of the sepsis survivors are going to have cognitive dysfunction. A third of them are going to be in that revolving door. We'll send them home and they're going to come right back. I was just talking to a student after my morning class, and the exact same thing. They sent somebody home, a family member home with sepsis. They had, and she just looked at them. She goes, "They're sending you home looking like this? This doesn't make sense." You know, because they're sending them home, and of course they're coming back. If they do survive, then when we send them home, they're not going to be able to do all the things that they used to be able to do. So most often you'll have 1 to 2 limitations. Like, they used to be able to brush their teeth before they got septic and septic shock, and now they can't brush their teeth. We need to hire sitters in the home to help with activities of daily living. And the amputations, every day there are an average of 38 amputations in the United States as a result of sepsis. So today, 38 people are getting amputations from sepsis. So we are now, every 4 years, all the brainiacs on sepsis come back and review, and so the definition of sepsis may change over the years. But right now we're functioning on sepsis being a life-threatening organ dysfunction that gets dysregulated in a response to infection. And it can cascade downhill into septic shock, where the vessels dilate and we can't perfuse and death is imminent. So when you think of sepsis, I want you to think of hypoperfusion, subperfusion, not good perfusion. So anyone with poor perfusion is hypoperfused, all right? And this is the core, this is how sepsis works. And if we hypoperfuse 2 or more organs where they fail, we call that multi-organ dysfunction syndrome, MODS. I have eliminated the case study on Erin Flatley, but you do have access to her story. It's a newspaper article story. I want you all to read it if you haven't read it. I normally do a root cause analysis on what went wrong and why did not we save this girl. But her story is still going on. We're still not saving people. People are still dying because we didn't recognize sepsis. So we are going to learn today how to recognize it, because sepsis is a perfusion problem, and it stems from this hyper-inflammatory response that goes head to toe and creates this clotting cascade, pains involved, poor perfusion to the brain will have decreased cognition, poor perfusion to the kidneys, decreased elimination, poor perfusion to the lungs will have decreased gas exchange, and of course we're going to have decreased mobility. So let's look at the pathophysiology of what is going on with sepsis and septic shock. So we have the inflammation lecture, and all this is what you learned in inflammation gone wild. So if we look at the slide over here where we have this very good, wonderful arterial vessel, we have a blood vessel here, and you can see that it can squeeze down. You know, this blood vessel is working well. It's got the ability to squeeze down. So our vessels are designed so they can be elastic and receive blood, and then they can squeeze down and push the blood forward. So the blood, oxygenated blood, travels through the body, so every cell in the body gets their fair share of oxygen that's traveling on heme, right? So the only way that the cells get their oxygen off that heme is for the blood to flow. And so we have to have a good cardiac output, and the vessels need to squeeze the blood forward. All right, so that's normal. So then what happens is, let's say we cut our knee and bacteria gets in the tissue of our knee. So what will happen? The inflammatory response will happen because we have this bacteria that doesn't belong up in the tissues of my knee. So white blood cells get triggered to come. The neutrophils are the first on the scene, and the neutrophils are going to come to, they're going to travel through the blood vessels near this injured site. Because those neutrophils are the first guys that come and fight the infection. These neutrophils also will spray out chemicals that will cause, sorry, making sure it's not my mom, that will cause the blood vessels to dilate. And dilation is good because look at all these neutrophils that are traveling to the site of injury. We have a lot of neutrophils that are trying to congregate here. So the vessels will dilate. Well, when vessels dilate, look at your knee, your vessels are now dilating, so your knee might look red, or it may feel warm to touch. That's the inflammatory response. But then what happens is these chemicals that are sprayed out are going to affect the cells in the endothelium, and the cells now will shrink. Well, when the cells in the wall of the endothelial shrink, little holes are created between the cells. Well, this is great because those neutrophils now can squeeze out between the endothelial cells and get out these holes. The membranes have become permeable, right? So the neutrophils are squeezing out, and they can get up into the tissue where they can attack the bacteria. So that's wonderful. But the problem with these holes in these vessels are that they'll also let fluid inside the blood vessels leak out, and it will third space. It will leak out into your tissue, so your knee will start to swell, right? So we've got this swollen knee because we have fluid leaking out of the vessels into the third space, or so we have third spacing going on, swelling. And we have dilated vessels, so we see our knee is now red, and then the vessels are dilated, so we touch our knee and it's warm. So that is a local inflammatory response. The problem with sepsis is this response is going on from head to toe. So we're vasodilated and leaky from head to toe and in all of our organs. So we're leaking fluid out into our lungs, right? Where these vessels are going by the alveoli, we're leaking, and so we're decreasing diffusion and we can't oxygenate. So this, instead of being a localized inflammatory reaction, it's now systemic. It's head to toe, and this is going on in all your vessels from head to toe. So now, if you'll remember, Miss Garrison talked about when we had inflammation in the heart, she talked about calling all platelets. Well, here in the inflammatory process, the platelets are being called too, for two reasons. Number one, the platelets are going to want to try to find the endotoxin off the bacteria, and they're going to want to try to clump off around it, right? And they'll want to clump off around the bacteria as well. They also want to clump up these holes that the fluid's leaking out of the vessels. So all these little platelets are going to clump up and try to make little clots between all these little cells of the endothelium. So that's a lot of clumping and clotting. So what happens is our platelets get used up. Right? So we have this hyperactive micro clotting going on from head to toe. And these little clots are floating around in our blood vessels moving forward. And then they're getting clogged up in our kidneys and in our brain. They're getting clogged up in the tip of our fingers. And we can see like little petechiae or little black or blue spots. We can see mottling on their trunk or on their thighs. There's these big blue spots. So this clotting, these microclots are happening and using up all of our platelets, and so then we can start to bleed. So there's the sepsis can trigger a syndrome called DIC, disseminated, like all through the body, intravascular coagulation, clots. Microclots are everywhere. So we're leaking and we have microclots and we're vasodilated, right? That is, and it's happening head to toe, and that is septic shock. We have to formulate our nursing diagnosis for septic shock so we can figure out what things to do to help fix this person. So we have a decreased perfusion due to the massive global vasodilation. Just showed you the picture where vessels are all vasodilated. So of course our blood pressure falls, right? So we got massive global vasodilation. We got this exaggerated microclot formation, so that's going to hurt perfusion, right? We have this massive capillary leak from head to toe, so we're third spacing, and we're losing fluid, so our blood pressure's falling. And perhaps we could even have outright bleeding because we've used up all of our platelets, and now we're in DIC and we're bleeding. So we have a decreased perfusion due to all these things secondary to being in the state of septic shock and possibly DIC. Now, in DIC, you're going to see, like we said, the decreased platelets. You're going to also see decreased fibrinogen because, anything that makes clots is going to be decreased. You'll see a very sky-high increased D-dimer. A D-dimer is just a test to determine if somebody's got a clot. Your D-dimer will be elevated if you have a DVT or if you have a pulmonary embolism. Any clot anywhere is going to cause a positive D-dimer. It's just that in DIC, the D-dimer will be super, super high. You'll also see increase in fibrin split products. They may also be called fibrin degradation products, just meaning fibrins being broken down, right? And then you'll see this prolonged PT. It takes them a long time to clot, so they bleed. So it's very upsetting if your septic shock patient cascades into DIC. But anybody in any kind of shock has a decreased perfusion, and they're hypotensive. All right, so inflammation, this is just inflammation gone wild. And it's going wild in the lungs, so we're leaking in the lungs. So if you're monitoring their SCVO2, by the time the blood gets back to the right side of the heart, you're seeing like numbers down in the 50s and the 40s. So you have to memorize this slide. This was the original way for decades that we were determining if somebody was septic. We were saying, okay, they have 2 of the SIRS criteria, and plus a suspected or a actual infection. So you just have to memorize the SIRS criteria. So because we still use it, it's not perfect, but it is a way to see, get some kind of objective data using the surge criteria if the patient, where they are in the sepsis category. So this is the temperature above 100.4, or they can't even spike up in temperature, the opposite. Their temperature is on less than 96.8. Heart rate faster than 90, respiratory rate faster than 20, and because they're breathing fast, then they'll be blowing off more CO2, so PaCO2 less than 32, a white blood cell count above 12,000 or less than 4,000, and greater than 10% immature bands. And immature bands are just little immature neutrophils. Remember, when there's a bacteria or a fungus or a virus has evaded our into our body, the neutrophils are the first on the scene. Our body is going to be like a neutrophil factory, making neutrophils. Well, we get so hyper and hyped up, gone wild, inflammation gone wild, the body starts sending out neutrophils that are immature, those are called bands. So if you see a lot of immature neutrophils or bands, that's a sign of sepsis. It's part of the surge criteria. But you do need to be aware that a patient can have SIRS and look like they have two of these things and plus a suspected infection, but they don't have to be septic. So what we were finding was like people that had big traumatizing surgery, like open heart surgery, that was a lot of trauma, and they were having the SIRS response, but there was no infection, but they were having the SIRS response. So, it's not a perfect way to assess for sepsis, right? But we still use we always say, hey, does he have a fever? When we're asking if somebody's septic or somebody has an infection, does he have fever? Is he breathing fast? That's typical. But so let's use that. So you have to memorize this. It's in your handout. If you have your handout in front of you, just turn to the surge criteria, and we're going to look at a patient, and we're going to apply this and say, does the patient have sepsis or not using the surge criteria? Well, let's look. Temperature 100.1. No, that's less than 100.4, right? And he's got a heart rate of 85. Well, that's less than 90, so that's not a ding. His blood pressure wasn't even part of the things that we're looking at, right? And respiratory rate, okay, respiratory rate is high. It's 24, so he gets 1 point. And then he's awake and alert only by 2. He's confused the time, and he fell at home. Well, mentation is not part of the SIRS criteria, right? But his urine is cloudy and strong. It smells strong. So yeah, he, looks like he's got an infection, but I only got one of the SIRS criteria. So by using the SIRS criteria, we're not going to say he's infected. No. So we're going to, maybe send this patient home, right? So then in 2016 comes out, the evidence comes out that, y'all, hands down, the quick sepsis-related sequential organ failure assessment is so much better. They call it the quick SOFA. There's a quick SOFA that has these 3 elements, and if you score a 2 or a 3, you can score as low as a 0 or as high as a 3. If you score a 2 or a 3, that's a positive result. So, and it's 3 easy things to memorize. Easier to memorize than that surge criteria. So the Q SOFA was turning out to be a better tool for identifying sepsis quick. And that is altered mentation, so new or worsened altered mentation, respiratory rate equal to or greater to 22, or systolic blood pressure less than or equal to 100. All right, so that's pretty easy. So let's go back and look at that same patient. He's got a temperature of 100.1. Well, that's not part of the Q SOFA. He's got a heart rate of 85. That's not part of the Q SOFA. But he's got a blood pressure of 100 over 60. Well, the systolic is equal to or less than 100, so that's 1 point. Respiratory rate is equal to or greater than 22. Yep, that's another point. And then he's got that altered mentation. He's confused to time, and he fell at home. Yep. So he scored a 3 on the Q SOFA, right? and he's got the cloudy, strong-smelling urine, so we're suspecting he's got a urinary tract infection. So this patient, we're going to realize, oh, he's got sepsis. So we're going to look a little bit, we're going to watch real carefully. That's a low blood pressure. We're scared. We know that sepsis can easily cascade down to septic shock quickly. So, and he is 87 years old. He's going to be admitted to the hospital. We're not going to send him home. So, using the QSOFA method, what assessments are needed to identify poor outcomes associated with infection? So, we just learned D, you need to collect the systolic blood pressure, the Glasgow coma scale, and the respiratory rate. So, it's quick and easy and a helpful tool. So in 2016, we're all gaga over using the quick SOFA. If we score a 2 or a 3, then we're obligated to doing the full, complete SOFA, which I'm going to get to in a second. Here we go. So the answer is D, right? We're going to look at blood pressure, Glasgow coma, and respiratory rate. So here is the full SOFA. If I score a 2 or a 3 on the quick SOFA, then I need to kind of do a head-to-toe assessment in hypoperfusion, and I'm going to use labs to help me. I'm going to use physical assessment and labs to determine from head to toe if this patient has sepsis-related hypoperfusion. And hypoperfusion makes organ failure. All right, so here's the grid. We're going to look at the lungs. Is there hypoperfusion to the lungs? Well, how do we determine that? We calculate our PF ratio. And we learned how to do that in Oxygenation 1. We get our PaO2 divided by the FiO2 in decimal form. And we already memorized that if it's less than 200, they're in ARDS. They have a horrible perfusion to their lungs. Horrible. They're on the ventilator, right? If they're between 200 and 300, they have acute lung injury. But typically, all of us healthy people, our PF ratio should be greater than 400. So using this grid, we calculate our PF ratio, and if it's greater than or equal to 400, they score a 0. All I want you to do is memorize the 0 column. This is the healthy column. And I want you to know anything less than 400, they're going to start getting points. And the more points that we're getting, the worse off they are, right? If they scored a 0, then we got a healthy person using the full SOFA. So PF ratio is going to be how we determine perfusion to the lungs. So we need a set of ABGs, and we need to know how much oxygen that they're on at the time the ABGs are drawn. So I can calculate the PF ratio. We also want to look at platelets, because we see that in sepsis, with all these microclots everywhere, they develop thrombocytopenia, decrease in platelets, right? Platelets get used up. So we should see a patient with greater than or equal to 150,000 platelets, or greater than 150 times 10 to the 3, whatever. And anything less than 150,000, they're going to start accumulating points. So you see, as the platelets go down and down and down, the more points that they accumulate on this assessment. Now we're going to look and see, how's perfusion to the liver? Well, what's my bilirubin? If it's less than 1.2, they get a 0. They're healthy. But as perfusion, as impaired, we've got these dilated vessels, and we got poor vascular resistance, so we're not perfusing, we're not pushing blood through the liver. The liver cells aren't getting all the oxygen that they want. So we start to see the liver failure, and the bilirubin goes up. The higher up the poor perfusion is, higher the bilirubin, the poorer the perfusion is to the liver. Then cardiovascular, we want to get our MAP. We know that the MAP should be greater than or equal to 70 for a healthy person. That would be a 0. MAPs that start falling down less than 70 are going to start getting points. And then we'll get more points if we have to pull out dobutamine or dopamine, and even more points if we have to pull out epinephrine or norepinephrine or go up on the dopamine, and even more points if we have to go up on the norepinephrine or up on the epinephrine drip or up to the full highest dose of dopamine. So it just lets you know the bigger the score on this assessment, the worse the perfusion to their organs are. Now, to look at the brain, we're going to do our Glasgow coma. Everyone should be at 15, right? And then as they start to decline, the perfusion to the brain will be worse. Now, my dad had dementia when he was living, and so he never entered anywhere with a 15. He entered at a 14. Okay, that's fine. He's a 14, but now he's septic, and now he's gone down to a 12. So we wouldn't expect him to have a 15, but you see we're seeing a decline, so he's going to get points for that. As the perfusion is poor to the kidneys, you're going to see creatinine to start to go up. So our creatinine, just like our bili, should be less than 1.2. And as perfusion to the kidneys is impaired, our creatinine is going to go up. And as our creatinine goes up, once it gets up around 4, you're going to start seeing urine output impaired to like less than 500 a day. And once the creatinine gets up even higher, you might see less than 200 a day. Okay, so that's telling you poor perfusion to the kidneys. So like I said, for answering test questions, I just need you to memorize the normals. All right, so I want you to recognize that, okay, if the bilirubin is 3.5, that they're having hypoperfusion, right, to the liver. If you see their platelets are less than 50, that this is part of that hypo perfusion, that coag response. Now, to convert that 0 column to something that makes sense to me, I just draw a stick man. And I just label my stick man, kind of like with I have my Q SOFA. I've got to check my LOC. I've got to check my respiratory rate, and I've got to check my systolic blood pressure. All right, that's my quick SOFA. And then my full SOFA is, okay, what is my Glasgow coma scale? What is my PF ratio? Need a set of ABGs. What is my MAP? For the liver, what is my bilirubin? What are my platelets? And for my kidneys, what is my creatinine, my urine output? And then don't forget, and this was a big stress, that in your head to toe assessment, if you're worried about perfusion, you be diligent about all 4 extremities doing a capillary refill time. And get your second hand out. Don't just, guess it. Get a second hand out and go 1 1,000, 2 1,000, 3 1,000, right? Measure it with your second hand, because we want to be able to differentiate the difference between 3 seconds and 4 seconds, or 2 seconds and 5 seconds, right? So we want to see, are they getting better or are they getting worse? So the story about Aaron Flatley, you may or may not have read it. You have access to it. Please read the story about Aaron Flatley, who is a young, beautiful girl who died of sepsis because she was failed to be rescued. We failed her horribly. And unfortunately, although I'm learning from her, the mistakes that were made on her, and you are too, it's still going on out there. So we have to do better. So number 1, say the word. I want you to say the word sepsis. Don't be afraid to tell a doctor sepsis. Use the word sepsis. Do you think she's sepsis? She looks septic. So in her story, Aaron Flatley's story, I would have called the doctor and said, here's the situation. The patient looks septic. right? So you're saying the word, so they're now thinking sepsis. And then B, the background. She just had surgery last Wednesday. And my assessment, she's got pain, oliguria, cloudy, foul smelling urine. She's got crazy leukocytosis. Her WBCs are sky high. And she scored a 2 on the Q-SOFA assessment. So IR recommend we implement the sepsis bundles and do the full SOFA assessment with labs. So say the word sepsis. So the 2021 guidelines came out. The guidelines are reviewed every 4 years. So every 4 years, all the brainiacs get together and they review all the randomized controlled studied research that's been done, and then they make suggestions to us for how we need to be handling sepsis. So the November 2021 guidelines just came out, and the new news is, well, SIRS is not perfect. Q-SOFA, full SOFA is not perfect. And there's other assessments like the Modified Early Warning Score, the MUSE, they use it in UK, the MUSE warning system, the NEWS warning system. There's all kind of, the Apache score, there's all kind of assessments that can be done to determine, does this patient need to go to ICU, or is this patient high risk of dying? So not one assessment is the best. So what you need to do is see how you're assessing at your institution, at your hospital. How are we identifying sepsis early? What are we doing? How do I activate the sepsis? Are we calling a code sepsis at this hospital? Are we calling a rapid response? But we need to have our protocols and to identify it early, to communicate it early, and then to implement the sepsis bundles immediately. All right, so that's just a link to the MUSE score. Let's see if I can open that up, hyperlink that. Somebody asked me earlier. MUSE. So this just takes you to MedCalc, where MUSE, they look at the systolic blood pressure, they look at heart rate, they look at respiratory rate, they look at temperature, and then they add, is this a COVID patient? So that's part of the modified, or the MUSE assessment. I don't need y'all to memorize that at all, but just letting you know that that's what that assessment is. Where'd I go? Got lost. MUSE. Okay, so once hypotension begins, they rapidly start declining, and that's what happened to Aaron. And people just, they can die right in front of your eyes. So you have to notice what you're trained to notice, and then react to it. So once hypotension begins, they can die very quickly. Every hour we wait to give a septic patient their antibiotics is a 12% reduction in survival. We're going to start them on an empiric antibiotic, which is just a broad spectrum antibiotic. If it looks like a urinary tract infection, these are the empiric antibiotics that we use for urinary tract infection. If they're coughing up green, these are the empiric antibiotics that we use for pneumonia, right? But early identification is key. I can't stress it enough. So when the sepsis bundles, and bundles are just little interventions that we bundle together, and when we do them all, we create good outcomes for patients. Just like you bundled your care for the ventilator patient, the VAP protocol, right? So we are bundling patient care, the interventions for the patients with sepsis. Medicare, and when these bundles came out, we had 3 hours in which to do certain things of the bundle, and we had within 6 hours, we need to do the rest of these things, right? These interventions. What we were finding is that, wow, we can do this all in 1 hour. We don't need to take 3 and 6 hours. We can get more aggressive, and we can get a jump on sepsis. So the goal is to try to get the 3 hour bundles and the 6 hour bundles all done in that first hour, or we call it now the hour one bundle. But Medicare still tracks it as 3 hour and 6 hour bundles, and they pay and reimburse us. If you did all these within 3 hours and all these in 6 hours, we're going to pay you, right? And then we use early goal directed therapy. And you've been doing this. You've been doing this with your propofol. You were titrating up on your propofol to try to get that RAS of 0 or -1 or whatever you were trying to get. You know, that patient's response was triggering the nurse to either go up or down on that propofol drip, or keep it just right where it was, or to turn it off because you're killing the patient, right? So y'all have been doing early goal directed therapy already, but we're going to continue to do that with sepsis. So what is our hour one bundle? Number one, measure, and you got to memorize this. Memorize the slide. You need to measure their lactate.
Dr. Uddo, I'm so sorry to interrupt you. I just want to make sure that the outline that was already posted, that was the first one I printed. I know you went down to 2 hours, but is it the same handout?
Yeah, I just uploaded a handout with I don't know. I just
This handout has the Aaron girl on the cover of it.
yeah. So it still has the Aaron on the cover, but I did do a spring 2022 handout. I did update it. There's just a couple of little tiny things. It's basically the same thing.
Okay.
I got rid of like the little review questions at the end.
Okay, that's what I was wondering if I had the right one. Thank you. Sorry to interrupt.
So, but the hour one bundle, so this hasn't changed. So it is number one, measure the lactate. And we all know anybody in shock, lactate goes up because perfusion's bad, right? Anybody in shock has a perfusion problem, right? And when we don't perfuse and we don't get oxygen to all the cells now change from aerobic metabolism to anaerobic metabolism. They start making lactic acid, and our body doesn't like to be acidotic, so we start making, the body will start making lactate, a buffer to try to get our pH between 7.35 and 7.45. So lactate is a very quick, easy lab to get the results very quick, and it will guide us in how to handle the patient. Like, so somebody that's in horrible septic shock will come in, their lactate will be sky high. Your lactate should be less than 2. So let's go ahead. The first thing that we want to draw is that lactate and see how bad is this hypoperfusion. How bad is this septic shock? How bad is this shock? Then number 2, we want to get 2 sets of blood cultures before we start the antibiotics. Now, they need their antibiotics. So if there's something going on and you're sticking and sticking, and you can't get the blood cultures, well, then you just got to give the antibiotics. You know, if it's delaying you giving the antibiotics, you're going to have to just skip over that. But in a true perfect world, you'll get your lactate, you'll stick and get your 2 sets of your blood cultures, and each set will have an aerobic and an anaerobic bottle. And then you'll give your broad spectrum antibiotics. Hurry up about it. You want to get those antibiotics in them as fast as you possibly can. And then we need to bolus them. So they need fluids, because remember, their vessels are dilated and they're leaking. So we need to put fluids in there. So the bolus that they need is 30 mils per kilogram. So you're going to have to weigh them. And then multiply their kilogram weight by 30, and that is their bolus that they need for hypotension. Now, if they're not hypotensive, you don't have to bolus them unless they have an elevated lactate of 4 or greater. So, you know, oddly, if they had a lactate of 4 or greater, usually they're hypotensive also, but there's been situations where they were not hypotensive, but their lactate was, 5. It was greater than 4. So bolus them, that same 30 mils per kg. Now, we can, and that's just the starters. That's just the bolus for starters. So you may give up to 8 liters to this patient, but we will bolus them. If they look like they like it, we'll give them another bolus. If they look like they like it, we'll give them another bolus. You know, if they're responding, their capillary refill looks better, their CBP looks better, their MAP looks better, whatever we're looking at is looking better, we'll give them another bolus. But then if we've given them the boluses and they don't seem to be responding now, so maybe we've maxed out on we've got enough fluid in them, now it's time, and they're still hypotensive, now it's time to squeeze. And we get a vasoconstrictor or a vasopressor, and that's our norepinephrine. And we're going to put that on a continuous infusion, and we're going to start titrating up in little increments until we can get that mean arterial pressure of 65 or greater. Okay, and then we're going to remeasure our lactate. If that initial lactate was elevated, we may be doing lactates every 2 to 4 hours. So I just have, this slide just has a couple of connections to some good YouTube movies. One's on the Hour One Bundle, and one is on just pathophysiology of sepsis, which I happen to like. After you give that that first fluid bolus, you're going to reevaluate. You're going to say, did they like it? So you're going to do a focused exam with vital signs, pulse, skin turgor, cardiopulmonary assessment, and do not forget to do the capillary refill. That is a very important physical assessment. If you don't have a physician at the bedside to do a focused physical head-to-toe exam, then we need to do at least 2 of these hemodynamics. So CVPs, SCVO2s. They can even do a bedside ultrasound. And at my hospital, we're doing that more and more. I know that Leslie's in the class today, and her team, I think it was her patient that they came in, you know, he was in septic shock and he wasn't looking good, and they brought in the bedside ultrasound to see what his stroke volume was in his left ventricle.
Yeah, with my patient.
Yeah. And do you remember what they said about his stroke volume, Leslie?
No, I don't remember hearing that. No.
Okay. But he was doing this whole hemodynamic, you know, I was like, oh, hope Leslie's listening, but you were so busy IVs and putting in Foley's and taking off norepinephrine, but norepinephrine on. I mean, shoot, giving the antibiotics, starting an IV. Oh, it was a busy day for you.
Yeah.
Yeah, it's hard when you get like this fresh sepsis patient. They go downhill really quick.
Yeah, it was crazy.
What was the biggest thing that you walked away with knowing about sepsis, caring for a sepsis patient?
Just how quickly he declined throughout the day. I mean, just from 7 o'clock when I started assessing him and working with him, I mean, within the hour, he became even more delirious, and it was just going straight downhill from there very quickly.
Right, and I think that y'all had him on norepinephrine. You took him off, but then we ended up like right when we were leaving. I think his systolic blood pressure went down to 70, and so nurse ran back in there to hang the norepinephrine back on.
Yeah.
But yeah, they go downhill fast, and it's stressful. It's like you didn't leave that room. She did not leave this patient's bedside for hours. It was nuts. So if you don't do a full head-to-toe assessment, then we can use things like ultrasound, passive leg raising, machinery that can give us, like with each stroke of the heart, the stroke volume variance. This is a link to a patient. He's the first COVID patient. I guess I'm going to show it. Just to let you know that, with COVID, we are having like the COVID-related sepsis. So it can be a virus. So I'll just show you.
Cheers for the COVID victim known as Patient Zero. Rick Garfield lost fingers on both hands. After 64 days of hospitalization, he walked out of St. Joseph's Providence Hospital in Burbank to thunderous applause.
I have half my fingers left on this hand. I have 4 of my fingers were amputated.
He says his body had an autoimmune response that turned on him.
I had sepsis. I had MRSA. I had a pulmonary embolism.
In February, the LA businessman and his buddies went skiing in the Italian Alps. It was before most Americans had heard of COVID-19. All 13 friends tested positive. Greg was put on a ventilator and given a 1% chance of survival.
I turned to one of my ICU nurses and said, I'm scared. I don't want to die.
His girlfriend, AJ Johnson, was allowed to visit just twice.
It was a whirlwind. It was really scary. Just telling him that we know who he is. We know that this is not going to take him down. We're like, you better fight.
She was with him during that triumphant walk out of the hospital, along with his sister. Greg says he wants everyone to take the virus seriously.
I'm here to tell you, this can happen to you. And there's no rhyme or reason behind it.
And this nurse from Florida who worked the front lines of the pandemic now finds himself paralyzed from the neck down. 22-year-old Desmond Silva contracted the virus 2 months ago. Initially, the symptoms were mild, says his girlfriend.
He had a stuffy nose for a couple days, but it was very minor.
So then he recovered, right?
Yeah, he tested negative, went back to work, and was fine. No symptoms.
Then last week, he came down with a spinal infection caused by COVID-19, which led to paralysis.
It just makes no sense. There's no underlying health issues. It doesn't make any sense.
Harvard University physician Dr. Ashish Jha says COVID-19 remains a confounding disease, and there is much.
And it's like this COVID has just like made us step up our game so much with infection and sepsis, and and typically we always think of old people dying of sepsis, but seeing Desmond at such a young age being so impaired by an infection that was sparked by COVID, it's just it just injures me morally. He shouldn't be, somebody that young just shouldn't be dying. We've been traumatized by the deaths that we have all seen and experienced. But just since we began this lecture, 25 people in America have died from sepsis. And just since we started this lecture, 1,000 people have died around the world from sepsis. So it's everywhere. You're going to see it, and that's why I need you all to be sepsis warriors and find it and communicate. Use your mouth and say the word sepsis, and then start the sepsis bundles. In your handbook, your handout. I have several little patient scenarios in here, and I'll ask y'all just to go through your handout and use the surge criteria and the Q SOFA to determine what their score is, and would you call and say, hey, this patient, should the sepsis bundles be started? So that's a great little activity for y'all to do on your own. And we're going to go ahead and take a 5-minute break, and we're going to come on back. So I'll see you back here in 5 minutes. And if anybody has questions, I'll stay here and answer any questions that you have.
I have a question, Dr. Uddo. So going back to your slides about the SOFA, the Q SOFA, you mentioned the MAP should be above 70. And then when you were talking about above 70. And then when you were talking about treatment, you said above 65 for the MAP. So should we go by those two numbers, or is there one number for testing purposes?
No, you did very good. Very good observation. So we know that the human being, a normal healthy being, should have a MAP greater than 70, right? And anything less than 70 on that full SOFA, we're gonna say, okay, they're getting worse and worse and worse, right? So we want that MAP to be greater than 70. Now, when we go to hanging norepinephrine, or vasopressors, when we hang those vasopressors, they are going to constrict our vessels. They're going to constrict the vessels in our fingers and our toes so much that our fingers and toes are going to get cold, right? Because it's going to divert blood flow to our brain, our heart, right? So our fingers get cold and blue, and they get hypoperfused from the sepsis as well as from these potent vasoconstrictors that we're using. So because these vasoconstrictors are so toxic, the studies have shown we can lower what our goal is for MAP while we're on vasopressors. So that we use less vasopressors. We want to use the very least amount of vasopressors that we need to sustain perfusion.
Mm-hmm.
Right? So with that being said, we'll lower the MAP when we start trying to control the blood pressure with norepinephrine.
That makes sense.
So we use less norepinephrine.
Okay, thank you.
Thank you. All right, I think it's been 5 minutes. I'm hoping that y'all are back. I just want to move forward. Like I said, every 4 years, all the brainiacs on sepsis get together. They have a big world conference, and then they just determine what are the new sepsis guidelines based on the randomized controlled studied researches that have been conducted over the last 4 years. So it's a medical emergency, and we recommend treatment and resuscitation begin immediately. Finding the source of the infection is paramount. Start antibiotics within 1 hour for both sepsis and septic shock, because again, sepsis can cascade to septic shock very quickly. And sepsis is just that slide I showed you. We got vasodilation, we got microclots, we got the infection, but now we're going down into shock. Our blood pressure is low, our MAP is less than 70. Right? So, and then we need to start them on empiric antibiotics. And empiric antibiotics are those broad spectrum antibiotics. They make maybe 2 antibiotics. We're going to bolus the patient. We're going to calculate if they're showing sepsis-induced hypoperfusion, and that's going to be hypotension. Then we're going to bolus them with 30 mils per kilogram of a crystalloid fluid, and that's going to be normal saline or lactated ringers. And that should be given within the first 3 hours. But once again, we're trying to do those 3 hours and 6 hours bundles of care in hour one bundle in the very first hour. And so then we'll get fluid boluses, then we want to reassess the patient and get some hemodynamic numbers and see, hey, did they like the fluid bolus? And that will guide us to see, maybe we should give them some more fluids. Crystalloids, we said, now if they get set up to like 7, 8 liters of fluid bolus of crystalloids, that's a lot of crystalloids. So then and only then you may see albumin being ordered in addition to the crystalloids to try to help keep that fluid in the vessels, but the vessels are leaking. Albumin will leak out of the vessels too. So this is about the question of why didn't we learn MAP is 70, but why are we only titrating up on the norepinephrine to get a MAP of 65? Because the studies are showing us that if we titrate up to 65, we get exactly what we need as far as perfusion. The evidence guides us, and we can use less norepinephrine, and the patients do better. So you know, on human beings, normal healthy human beings, we want MAPs to be 70, but when we are in septic shock or any kind of shock and we're using a vasopressor, we're only going to titrate up to 65 because that's what the research is telling us. Norepinephrine is our first choice of vasopressors. If we max up our norepinephrine, let's say we go up and up and up, and the doctor writes orders like max dose of norepinephrine is 3 mics per kilogram per minute, and we're up to 3 mics per kilogram per minute, and we're still having blood pressure problems. The bedside monitor is still ringing, the MAP is still low. So then what we can do is keep the norepinephrine at full throttle where it is, maxed out, and then we can go get another bag of vasopressin and hang that and run that like at a set rate, just at a continuous infusion to help, like at like 0.03 units per minute to assist that maxed out norepinephrine. We could even use an epinephrine drip to help max out and help the norepinephrine work. And sometimes once we hang the vasopressin or epinephrine drip, we can actually now back down off the norepinephrine. That's a weak recommendation, but it is one. So use norepinephrine first. MAP of our target MAP is 65. Consider getting an arterial line, because we like dynamic assessments. You know, so we're getting a dynamic assessment. We're getting a blood pressure with each beat of the heart. And if we're titrating up on the norepinephrine, that art line is giving us blood pressures with each beat of the heart. So it's much easier to titrate our drugs. Plus, we can draw blood samples. Consider, if the norepinephrine not working, consider hanging some vasopressin with it. And then the other thing is, don't forget, the sepsis can have like effect on contractility. So these patients can also develop cardiogenic shock. So they, you know, you may see having to hang a little dobutamine drip on these patients too. If the shock is not resolving quickly, recommend further hemodynamic assessments to determine, you know, what kind of shock it is. Let's get a cardiac output. Let's get a cardiac index. And of course, we like those dynamic assessments over like dynamic over those static assessments. Lactate can guide our resuscitations. So we can give, if somebody comes in with a lactate of 7, then we give them like, you know, let's see, 3 liters of fluid bolus, and then we do another lactate. We say, oh, the lactate came down to 5. Ooh, it seems like they like that fluid boluses. Let's give them some more fluid boluses. So lactates will help us determine interventions to do as well. So in summary, identify early, start early, give them their fluid boluses, give them their antibiotics. Do frequent assessments. So you're going to do interventions and reassess. Do another intervention, reassess. So intervention, reassess, intervention, reassess. And then try to normalize your lactate. Try to keep giving boluses until you get your lactate down. You should have a performance improvement program at your hospital that follows up on you, just like you did when you were getting your patient to the cath lab for an MI, and you had like, from the time they came in through the door to the time you inflated that balloon, you had like 90 minutes. Well, this is the same thing. We need to have a performance improvement team to come through and go, okay, here's a guy who came in with sepsis. How long did it take for y'all to call the code sepsis or call a rapid response or whatever? How long did that take you to do? And then when you did it, how long did it take you to implement the bundles of care? And that if we have, New York's got mandated public reporting, Medicare public reporting on sepsis numbers. So when we do this mandated reporting, it makes us step up our game and try to reach excellence in sepsis care. Try to get your cultures before you hang your antibiotics. However, these people are kind of hard to stick and hard to start IVs on, so you may be having a hard time getting your 2 sets of blood cultures. Well, don't let that, if the delay is making you nervous, it's stop the substantial delay and go ahead and hang the antibiotics. But ideally, in an ideal world, you want to get both sets of antibiotics before you hang the both sets of blood cultures before you hang the antibiotics. We suggest empiric therapy, and it may be a combo therapy using 2 different broad spectrum antibiotics. Once the results of our cultures come back, then we want to narrow down the antibiotic that we use to a target antibiotic. Antibiotic treatment should last 7 to 10 days. And we want to see daily assessment. Can we de-escalate our antimicrobials? And the procalcitonin lab will really be helpful. Procalcitonin goes up in patients that are infected with a bacterial infection, but they don't go up if it's a viral infection. So if you're trying to figure out, is this bacterial or viral, the procalcitonin can be helpful. And the procalcitonin lab can also be helpful too so somebody's got a huge infection, procalcitonin is really high, and you start the antimicrobials, and then you see, procalcitonin levels are all the way down. We can go ahead. We don't have to wait 10 days. We can stop the antibiotics after 7 days. So it's a good tool that physicians use to help manage the duration of antibiotics. Steroids are not normally used unless, you have this patient that is full throttle norepinephrine, it's got the vasopressin, and we're still having blood pressure problems. So if we see that we have a patient that's resistant to the vasopressor therapy, then maybe try the steroids. So you learned in Oxygenation 1 that most of your ARDS patients were due to sepsis. So in sepsis, and the lungs start to fail, the PF ratio starts to fall, start thinking ARDS protocol. That's the high peak, the low tidal volumes, turning them prone if their PF ratio is less than 150. Just the ARDS stuff. Glucose will go up in stress, so we want to try to keep their glucose less than 180. You may be putting them on an insulin drip. You may be doing AccuChecks every hour until you can stabilize their glucose. Get the blood samples from the ART line if you can, because those are more accurate than the little AccuCheck finger stick. And then don't rush to dialysis, but continuous renal replacement therapy may be what they end up needing, but just give the kidneys a chance to come back on their own before we start with dialysis. Feed them. If the gut works, we need to use it. So we want to feed them enterally with enteral tube feeding, and we need to start within 48 hours. So start enteral feeding, and you want to try to increase that enteral infusion until you get them up to a rate that will give them all the calories that they need in that day, But however, with perfusion being bad, this perfusion can be very bad to the gut. You may be having a hard time hearing any bowel sounds, right? So you may see trophic or hypocaloric enteral feeding ordered, where they're just getting like 10 mils an hour. That's not enough calories, but they're doing it to try to stimulate the gut and prevent germs from inside the gut from translocating or leaking out into the abdomen. So they also recommend against checking gastric residuals on somebody a septic patient that is getting enterally fed, because nurses were all too often turning off the tube feeding. And we don't want to do that. We want to keep, the only time we want to turn off the tube feeding is if we are really, really afraid they're going to aspirate. So if their stomach is all of a sudden out to here, super distended, yeah, then check for residuals. We use prokinetic agents for that, trying to get the gut to move forward. And then just remember, just feeding just that 10 mils an hour can help prevent translocation. Goals should be set with the family quickly. So within 72 hours of the patient coming in with septic shock, we need to sit down with the family and talk about goals. Where are we going? What are we going to do? Now, one thing that I find that us nurses can do a whole lot more and improve the lives of our patient is if we have the discussion with them about, if your family member survives this, there's this thing called post-ICU syndrome, PICS, or post-sepsis syndrome, PSS. And so these patients, when they go home, can have changes, emotional, physical, and mental changes. They can have delirium. 80% of our ICU patients have delirium already. So that number is disgusting to me. It is disgusting that is our norm in the ICU. 8 out of 10 patients having delirium. It's just horrible. And we need to do more to prevent the delirium. These people are our patients. They're not our prisoners of war. So, and then the limb amputations, be careful, watch your map. Don't let your map go up into the 90s if you're on a norepinephrine drip. Be vigilant about titrating down to keep that map at like 65, between 65 and 70, right? You don't want them to have too much of the norepinephrine. Because remember, amputations are rampant. There's 38 amputations every day for sepsis. Depression follows, and anxiety, loss of confidence and self-belief. 50% of our sepsis patients experience muscle weakness and fatigue. And then the cognitive decline from sepsis can equal that to a traumatic brain injury. So they can have a profound change in cognitive function when they go home, and it's shocking and upsetting. And they can, if they had dementia, their dementia will be worse. They can have hallucinations, cloudy thinking, poor memory, difficult swallowing, and poor sleep. So prepare the family for this. Get social services on board. Get your case manager on board to assist with this. The ICU is a perfect storm for delirium. And this girl, Nancy Andrews, is an artist and a filmmaker. She did this wonderful TED Talk. I love for y'all to click on this link and watch her TED Talk. But she talks in this kind of depressive, monotone voice about her experience in ICU, and that everyone that was coming in there were coming to choke her they were suctioning her endotracheal tube, and they bound me. They put soft wrist restraints on her arms, and they had rubber tubes clamped to my genitals and were swinging me from the ceiling. And that's what she was feeling about her indwelling urinary catheter. So morphine, fentanyl, we have all these drugs on board, and people are still using the benzodiazepine. So it's the perfect storm for delirium, and we're doing that to these people that we're supposedly caring for. So I recommend you watching her TED Talk. So who's at risk for delirium? The older, 65 years or older, dehydrated, infected, people on psychoactive drugs, people who aren't getting their 7 to 9 hours of sleep, people that we keep flipping the lights on and don't turn the lights off for them to sleep, people on prolonged mechanical ventilation, prolonged immobilization. That scares me more than anything is immobilization, because immobilization kills, immobilization causes delirium. One of the best things you can do for people is to get them up out of bed into a chair. I promise you, even if they're looking delirious, get your team in there and get them a chair, and I'm telling you, you're going to see an improvement. I promise you. That you may see low blood pressures, malnutrition, restraint. Okay, so all these things can cause delirium. A low blood pressure can cause delirium. Malnutrition can cause delirium. Use of restraints can cause delirium, sepsis, and untreated pain. So it's up to the nurse to modify all these risk factors. Delirium is not the same as dementia. Dementia is a long-term, chronic condition that's only going to get worse. Delirium is an acute onset that is due to one of these things: sleep deprivation, the vent, the low blood pressure, the infection, right? And then, but if you do have a patient that comes in with dementia, they're at a higher risk for developing delirium. So 60 to 80% of the mechanically ventilated patients have delirium. 50 to 70% of the non-ventilated ICU patients had delirium. And then if you, like that artist that talks about, she remembers these horrible, hallucinatory, confusing memories that were very, very real to her. Like these nurses coming in to strangle her, who were suctioning her. They were the enemy, and she was frightened every time they came in. Her heart rate started increasing. So she had PTSD from this. So even though they're these foggy, strange memories, they're very real to them, and they cause PTSD. And these families and these patients need to know about this. Delirium. So why do we care? Because delirium kills. Because patients are twice as likely to die 1 year after experiencing hospital-acquired delirium, and mortality rates we found were 75% 3 years after an episode of delirium. And my dad is a statistic. 3 years ago, he had a delirium episode in the hospital, and then he recently had more delirium. But he's one of these statistics. Try to get your older adults at home, get them out of the hospital as quick as you possibly can. And every time a patient that goes into the hospital who has dementia and then they have delirium, they go home, the dementia is even more advanced. So to think about doing things to address delirium or decrease delirium, use the word think, THINK. T for toxic situations. So do they receive a shock, dehydration? Are they on meds that cause delirium? Use tight titration of those meds. Look for new organ failure. And then H, hypoxemia. Are they hypoxemic? I, infection. Are they septic? Do your sepsis assessment. Are they immobilized? Then mobilize them. And then N, think non-pharmacological interventions, like put their glasses on them, stick their hearing aids in them, reorient them, turn the lights off, let them sleep. If you have those little red lights on your unit, those are wonderful for sleep. The nurse can come in and just flip on the red light. They stay sleeping, their room's not disturbed, but the nurse can see to do the things they need to do in there. We need to care about our patients. They are not our prisoners of war in our ICU bed. We need to do noise control, get them up out of bed, put them in the bedside chair, play music, put earphones on them, check their, and then K, think about potassium and other electrolytes. If you don't like using the Think version, use the Dr. Dre, doctor for disease review. Do they have sepsis, COPD, CHF? And then go to DRE, the DR, drug removal. That's where we start removing the drugs like the fentanyl, the propofol, and the morphine. We stop those drips and we see if they can spontaneously awaken and then spontaneously breathe. We'll turn this control mode over to spontaneous and see if they can wake up and breathe. And then E in Dr. Dre is environment. Look around your environment. What can I do to prevent delirium? Mobilize them, get them up, dangle them, put them in the bedside chair, help them with sleep day circadian. So during the day, open up the curtains. During at night, close them down. Stop giving these people benzodiazepines. All right, put their glasses on, hearing aids on. And implement the ABCDEF bundle. You may see it referred to as the A to F bundle. Same thing, just do it. This is where we liberate our patients. So we want to assess them for pain. B, wake up and breathe. That's where we do the spontaneous awakening trial and the spontaneous breathing trial. C, said we turn those things off. So we turn those drips off, propofol off, fentanyl off, wake up. And then the breathe. So we turn the vent over to spontaneous and see if they can breathe. And if they can, we want to extubate them. We want to be selective about good drugs to help them, because when they're on the ventilator, yes, they're anxious. So yes, they're uncomfortable. So use dexmedetomidine. That's your Presidex. That's so much better. Avoid using the benzodiazepines because those make delirium worse. And then here's the delirium assessment link. I love this guy. He does a good job demonstrating how to do the CAM ICU. The CAM ICU is in your critical care book on page chapter 236. I'll show you a picture of the CAM. I'm going to come back. I'm going to show that movie on how to do the CAM ICU. So we're going to do a CAM ICU or a delirium assessment every shift in ICU. And then E, we want to do early mobility. We're going to dangle them. We're going to get them up. Yes, they may be grabbing at things. They may be hallucinating and grabbing at things. Well, let's get them better. Let's mobilize them. They will do much better when you sit them up. I promise you. Start doing passive range of motion exercises with them. Get physical therapy and occupational therapy involved. And then get the family engagement involved. All right, so let me show the CAM ICU in motion. Okay.
You open your eyes and look at me. My name is Dr. Ely. And I just want to see how well you're thinking today. Can you do me a favor? Hold up this many fingers. And do the same thing with the other hand. Very good. Now, if you don't mind, squeeze my hand. I'm going to ask you to squeeze my hand again whenever I say letters. Okay, open your eyes. And relax your hand. Relax. Whenever I say the letter A, I want you to squeeze my hand. Okay? If I say a different letter, don't squeeze. S. A. B. E. H. A. A. R. T. And now, would you do me a favor and let me just ask you a few simple questions? Will a stone float on water? Yes or no? Will a stone float on water? Okay. fish in the sea. Very good. Hi, my name.
So that is what we do we're supposed to do every shift because we're charting that we're doing it. So we need to be doing it. How many of you in ICU have seen that done? Because that's the CAM ICU. And if we're charting that we're doing it every shift, we need to be doing that. So that's a whole new can of worms, charting things that we didn't really do. If you chart something, then you really need to do it. So don't get into that bad habit. So that is supposed to be done every shift in the ICU, and you have I think I have a picture to show you too. This is the same. The picture of this is in your critical care book. And basically, this is just what he was just doing. You want to see, hey, put your two hands up on the side. All right, now put two hands up, two fingers up on the other. And then he's just basically saying he's doing save a heart. And every time he says the letter A, he wants her to squeeze his hand. And so he's looking for inattention. And he's looking for disorganized thinking, well, stone fluid on water, blah, blah, blah. So then that's where we determine if we're seeing delirium, if delirium is present, or if it is not present. So that has to be done every shift. So what, like I'm saying, is we can do better. We can actually, I challenge you in ICU to go take this with you and do your CAM ICU assessment and then report that to your nurse. I want you to actually do it. Challenge. So next is don't give the benzodiazepines, but what do nurses want? They want their benzodiazepines because no one likes a patient that's picking and hyperactive. Where's Leslie again? How did you like your hyperactive septic patient? There was
yeah, it wasn't my favorite.
No, what did he look like?
So he also had Parkinson's, so he was very shaky, but he would kind of sit still for a couple minutes and then he'd be grabbing at things and asking for things that weren't there and looking around. At one point he told the doctor, he pointed at me as his daughter, and I was like, no, I'm not your daughter, they'll be coming later. But
right, yeah. And it's not grabbing at something up in the air.
Yeah.
Yeah, and throwing his leg out the side of the bed, so nurses don't like that. So what do they want to do? They want to like give them a benzodiazepine to shut them out, right? But that's the worst thing that we can possibly do. So let's try to say what's best for the patient, not necessarily best for the nurse. What's best for the patient, and let's try to avoid giving these people the benzodiazepines because. And did we give them a benzodiazepine? Yes, we did. We did. And then looking for other things, non-pharmacological things that you can do. Reorient them, get them out of bed, use sleep masks, close the little soundproof doors on the sliding doors, if you have them. Give them earplugs, give them headsets. Get their eyeglasses, control their pain, minimize how noisy we are outside their rooms or even in their rooms. Avoid the stupid restraints unless you're scared they're going to pull something out. And I think Leslie's guy was yanking on something, but he's yanking on his condom catheter, the tubing,
And he was trying to take the arm board off where his art line was.
That one, yeah, and the arm, but we did end up taking that off, but I wanted to put that back on afterwards. I forgot to do that. Anyway, so, they're a handful, but we can do better. And just keep trying. There's a lot of research about PTSD for some patients in the ICU with the PIC syndrome. So please let your family members know to be looking for PTSD, that this is so common and you may need to, get help for that. And we need to be quiet. World Health Organization recommends noise levels less than 35 decibels in the patient rooms, and the noise in the ICU patient rooms exceed that 70 to 90% of the time. So we can improve. The reduced sleep, increases pain. Both of those things will cause PTSD. So let's try to organize how many times we have to go in there. And then if we go in there, can we be quiet and not wake them up? Why does some phlebotomists feel like they can go in the room at 3 a.m. and go, hello, I'm here to get your blood? I'm going to come in your room at 3 o'clock in the morning and do that to you and see how you like it. It's horrible. It's just a horrible, horrible culture. And it's not cool. It's not nice. It's not polite. It's not healing. We wake them up. So let's let them sleep, change your ways, close the door, soundproof the door, limit interruptions, stop doing the things that cause delirium. So the nurse has to do a plan of care for patient ICU with sepsis to prevent post-ICU syndrome. What should the nurse do? All those things we just said. Get their glasses, get their hearing aids. Open the shutters during the day, close them during the night. Be quiet. Close the soundproof door. Don't give them benzodiazepines. Get them up into a chair. All right, that's the select all that apply answer. This was an activity I cut, but I have the link on your Canvas page and here on this slide. You can go to sepsis.org, and they have Faces of Sepsis, and they have all these people who have had sepsis and septic shock, and they tell their stories. And it's the story about Aaron took place, I think, in 2011, but it's still going on. People are still going to the ED, and they are being sent away to go home, and only to come back, to be sent away, go home, only to come back, and finally now that they're back, they're in full-blown septic shock and they're dying in the ICU. So we need to do better about identifying sepsis and not waiting till they're in full-blown septic shock to rescue them. So just think about your in sepsis, white blood cells, neutrophils, the macrophages. Macrophages will kind of like digest the content and make the pus. Basophils and eosinophils are part of the cell family that are involved in sepsis. Then the cytokines and the interleukins 1 through 6, tumor necrosis factors, those are all being sprayed, and they are all causing this, and that is sepsis. It's just hypoperfusion, and it's the inflammatory response gone wild. So we are going to have to make plans of care for these patients with sepsis, and we're going to have to use those hemodynamics that we learned in Perfusion 3 on page 14 of your handout from Perfusion 3, and we have to use them for caring for a patient in septic shock. So you cannot throw away any of those hemodynamics that you've already learned. We need them here also. So how will their hemodynamics look in septic shock? Well, their SCVO2, we already said, is going to be very low. The cells are in crisis, and they're not getting all the oxygen that they need. Our SCVO2 is going to be low. Pulmonary capillary wedge pressure will be low. Our pulse pressure is going to start to narrow. That means our stroke volume is narrowing. That will be low. Our systemic vascular resistance, we're in shock. It's going to be low. We're going to have that compensatory fast heart rate. Now, in septic shock, we can have a normal cardiac output because our SVR is so terribly low. So think about that aorta. That aorta is all super, super dilated. So the heart just has to barely beat, and it's going to just go spewing out because there's no resistance. So we can have initially in septic shock, we can have a normal cardiac output, but our SBR is super, super low. Our blood pressure is super, super low. We're in shock. We'll be measuring urine outputs every hour with a urometer. Urine output's going to be low because we have low perfusion to the kidneys. We're going to have a low systolic blood pressure because we have that capillary leak and the vasodilation. If they go into DIC, we could have bleeding. We're going to have the low MAP, so we want an art line, and we want that art line so we can titrate our vasoconstrictors. And norepinephrine is our #1 vasoconstrictor. Our shock index, we'll calculate that, and that will be high. Our PF ratio is going to be low. They're going to go down into artsy land. Their skin will be warm at first because, remember, the vessels are vasodilated, and they come warm up to the surface, so they're warm. And then as death is intimate, they become cold and blue. And just think about hypoperfusion like Stickman, and we're going to reflect back on everything that we learned from perfusion 3, and we're going to use those hemodynamics, and we're going to use those hemodynamic drugs. All these same drugs, these are still key players in taking care of the patient in septic shock. We remember lactate. How bad's the perfusion? Well, how high is my lactate? My lactate should be less than 2. If it's greater than 2, we think hypoperfusion. If it's greater than 4, we think shock. We think septic shock. Let's see, we're going to get 2 sets of blood cultures because if we contaminate one set, we have the other set that we maybe did not contaminate. So you want to grab your blood cultures before you hang your antibiotics. But if you're delaying and we got like 45 minutes and we still haven't gotten our blood cultures, then go ahead and hang the antibiotics. What else? Simple things we can do. We can scrub the hub. We can try really hard not to contaminate our patients. We can wash our hands. We can scrub the hub with chlorhexidine and alcohol pads. We can when we scrub the hub with about to give like an IV push, and we scrub the hub. We can sing happy birthday while we're scrubbing the hub, and then we can sing happy birthday again while it dries. That's what we're supposed to be doing. And we can improve. We can improve what we're doing. We can follow isolation protocols. How many times did you break isolation? How many times did you see nurses not put on the gown? How many times did you see it? I see it a lot. We could all do Q sofas every 12-hour shift. And then we can say the word sepsis. Is it possible to have 0 infection rates of our central lines and our urinary indwelling catheters? Yeah, it is. But we have to want it. And we have to live in a culture. We have to work in a hospital with a culture that says we are not tolerating central line infections. And that's where it comes into the story about planes and car crashes.
On an air crash at SFO.
When a plane crashes, it's kind of a big deal.
Continuing coverage now on the Asciana plane crash investigation.
Investigators try to figure out what went so terribly wrong.
People freak out. There's usually a big investigation and a bunch of policy changes to make planes safer.
A plane crash investigation committee from several nations, including the United States, are meeting in Tripoli to try and figure out what happened.
There's pretty much a zero tolerance policy for plane crashes in our society. And luckily, planes are very safe because of it. But when a car crashes, it's not really a big deal. No one hears about car crashes on the news. We've decided as a society that car crashes are a cost of a really convenient thing. It's not worth a big investigation, a bunch of news coverage. This video isn't about cars and planes. It's about hospitals. Sometimes doctors and nurses, despite their best intentions, hurt patients. A tricky procedure goes wrong, and the patient suffers or dies. This happens all the time in hospitals. One estimate says that at least 210,000 people die every year due to preventable harm in hospitals. That's a huge number.
I think we think of hospitals as this place where you go to get better, and that's just what happens. But there's a lot of risk in like going to a hospital. Like there's like a lot of things that go wrong, and they don't necessarily have to.
Some hospitals treat medical harm incidents like plane crashes, an unacceptable problem that needs investigation and policy change. Other hospitals treat them like car crashes, just a tragic loss of a risky business, but not ultimately preventable. The way hospitals react to harming their patients can have a huge impact on how often these errors occur. And that's what this video is about, how hospitals react when they harm their patients.
So I got interested in medical errors because it's this massive problem that we don't really talk about in healthcare.
Sarah and I headed to California to visit some people who would help us figure out how and why people are being harmed in hospitals, and whether or not it's preventable. I quickly realized that we were looking into something that was rarely talked about, but that had a huge effect on hospital patients around the country.
She loved dancing and running and jumping, and she never sat down. I mean, it's funny because we have these like families.
That's Claire. Her daughter Nora was born with an underdeveloped lung that required her to be in the hospital for quite a bit of time.
So we were using the beater, and I was like, oh yeah, there's a song called Beat It. So we put it on, and I mean, she used a beater as a microphone, and like I had a spoon, and we would just play it like as loud as possible, and she would just sing, Beat It.
During her treatment, Nora contracted something called a central line infection, which I'll explain in a minute.
The day before she got that first line infection, I had a friend over with her daughter, and like she was showing Nora how to do push-ups. I mean, it was just, you know, like totally fine. And then that was, I guess that, and then like 2 days later, she got the infection. Our lives completely, and Nora's life, completely changed with that first line infection.
A central line is a tube that is placed in a vein that goes right to the heart. It's given to patients who need medicine that's too acidic to go through a normal IV, or to those who need to get their blood drawn often. The tube stays there. People walk around with this thing in, and it gives doctors and nurses really quick access to the bloodstream. It's a super useful invention. But we're talking about putting a tube through veins that go right to your heart. Just as it's good for getting medicine quickly into your bloodstream, it's also a foreign object in your most vital organ. So if any bacteria gets in there, it's very bad news. Nora had 4 of these central line infections over the course of her life. That's way above average. Claire thinks that the Stanford hospital where she was being treated could have prevented them. And that's the question we're trying to answer. Can these infections be prevented?
There has to be a better solution. Like, this cannot be, because every line infection just took it out of her. Every line infection, you know, just took more out of her and more out of her. Did you say hi, Nora? Yeah, because I turned it that. You know, I turned it so she could see her.
So doctors and nurses have sanitation protocols when dealing with central lines, but even so, she contracted 3 more line infections while she was in the hospital. Her health was rapidly deteriorating as she approached her 4th birthday.
And she just like turned to me and was like, hold me. And so I picked her up, and she like put her arms and legs around me, and her head kind of went back, and she was sort of like gasping to breathe. And then she said, please help me feel better. And she just grabbed me around my neck, like so, I mean, I can still feel it, like so much strength, you know, like just squeezing me. And then she just basically lost consciousness and just kind of...
Nora died, her arms around her mother's neck, on November 22nd, 2013, just 3 weeks before her 4th birthday.
There were so many points along the way where like things could have gone differently, you know? And there were so many unnecessary mistakes that just led to that moment.
It's hard to know whether or not the line infections were the direct cause of her death. It's hard to disentangle everything that was going on with her to give a neat causal story of how she died. But what's sure is that these line infections caused her and her family immense suffering. Claire thinks that this should have never happened in the first place. She wrote a letter to the Stanford hospital where Nora died. She basically lined out the mistakes that she saw in the hospital and offered feedback on patient safety failures.
And there was no significant...
She got this letter in return.
Unfortunately, the placement of central lines is associated with a risk of infection.
There is a risk of infection, even in the best of circumstances, which can never be entirely eliminated. Please be assured that multiple procedural protocols are in place to promote hand washing techniques and minimize the chance of infection. We understand and recognize your feelings regarding Nora's care, and we apologize that you were dissatisfied with your experience at LPCH. Yeah.
So, were Nora's line infections just the result of a risky business? Or could they have been prevented? Stanford looked at central line infections with the car crash mentality, just an inevitable tragedy, instead of with a zero-tolerance plane crash mentality. But we headed north to a hospital outside of Sacramento that went 7 years in a row without a single central line infection. We wanted to figure out what they were doing to achieve this perfect record.
I was really interested in this concept of should there be any central line infections given what we know? Is zero possible? What does it take to get to zero? What are the obstacles there?
In 2005, this hospital had 11 central line infections. Research was just starting to come out on how to avoid these central line infections, and this Roseville hospital began to implement it. They had a few powerhouse nurses that were dedicated to making a difference, and they did.
We kind of thought you got infections. Yeah. It was no biggie. It was no big deal. It developed over time. We looked at people, we looked at equipment, we looked at skill set, and kind of all that came together to really develop a bundle that has been quite effective here.
You can't accept good enough. You have to go for eliminating those. If you've been at zero and you have an episode, you go in and you pick it apart and you do a root cause analysis and you say, what went wrong?
They treated line infections like plane crashes. A zero-tolerance policy was instituted, and they began to see results. We got to see these nurses in action as they inserted a central line. They suited us up in sterile dressing and began their work. The nurses were meticulous about the procedure. They had instituted standards of sterilization that assured minimum risk of infection.
Now what I'm going to do is, because my hand is not sterile, I touch the tourniquet. I'm going to take my first glove out. I'm going to throw away. Now it's still sterile.
And these weren't just compassionate nurses who had an intrinsic motivation to do right. Instead, they were operating in a culture where they were expected to do it right. It was a team effort, where they had ownership and accountability, where the line infections were unacceptable.
So that's my question to you. Are line infections unacceptable to you? How do you feel? Do you just go, oh, too bad, they got a central line infection, darn? Or are you like, ew, I am so sorry. We dropped the ball. We need to do better. So, unless we all take that type of look at central line infections, unless we change, then 68,000, people are going to die per year for central line infections. It will just keep happening unless we put our foot down and say, no, we're not going to let this happen anymore. We have a zero tolerance for line infections. So, how is it happening? Inadequate training. Is it that, we're not doing hand hygiene? Is it that we're over manipulating things? When we're putting IVs in, peripheral IVs, are we going in the antecubital? Because that's a place where you bend and you get infections easily. So, there's a whole lot of things that we need to look at. And, central line infections we're doing a lot of research on that, but we haven't even started really focusing on the peripheral line infections that we cause daily in the hospital. So Barb Nichols did some research in 2020 on these needleless connectors, the little connectors on the patient's peripheral IV are on the line, on the tubing that we access with the tip of our syringe when we give like an IV push medication. And she went and looked at all these needleless connectors and found 45% were contaminated. And once bacteria are in these connectors, biofilms develop where bacteria breed. It's like a little breeding pool. And then little pieces break off and they go traveling through the bloodstream. And she looked at people that were going to give IV pushes. and she saw them get an alcohol pad out, and then but they just did one little kind of like little minuscule sweep, and then they gave their push because they're in such a freaking hurry. But what they're supposed to do is take that alcohol and they're supposed to scrub the hub around the neck of it, around the top of it, and they're supposed to be singing happy birthday. And that just wasn't happening. So, and a lot has to do with how are we teaching you in nursing school? How are we making you do that in clinical? Are we just tired and not making you do that? Are we not conditioning you? Are we, how about the on the job training when you get to your hospital? Things are so crazy right now. You know, we're understaffed and don't have enough employees. It's a stressful time. So, no wonder since COVID, our infection rates on central lines went way up. And a lot of it has to do with that tubing coming, that long, I don't know, 20-foot tubing going underneath the closed door from the patient, on the floor, outside. We're not going in the room as much. So, of course, patients with COVID are getting central line infections a lot more frequently. There was a study where they say, okay, we're going to watch y'all. You are under observation. I'm going to be up here all day and we're doing a study. And they watched these nurses give IV pushes, and it said 31% of the clinicians did not even attempt to disinfect the hub when they went to go give an IV push. And they knew that they were being observed. So that makes you think they didn't know better. Some people have said, oh, I didn't know I had to scrub the hub. I didn't know I had to wipe the hub before I gave an IV push. Like, oh my goodness. So that was kind of like, oh my God, how are these nurses coming out of nursing school not knowing this? So another study showed that only 10% of clinicians followed hospital protocol for infection control. So the good news is once this was found out and then they did training to improve compliance, the training worked and compliance was improved. So we are trainable. And that some units even used a time buzzer system that they would tap when they were scrubbing the hub, and that helped condition the nurses on that unit. But this just seems to be the best thing. If you can just sing happy birthday while you're scrubbing the hub, that takes about 15 seconds. Sing it again to let the alcohol chlorhexidine dry. Oh God. And then just never bring that one alcohol pad in there with you. Open it up, wipe the needleless connector, and then give your saline, and then pick up that dirty pad that you threw on the bed that you just used and use it again before you give the IV push. So we're seeing nurses do that horrible habit. So each time you need a wipe, you need open a clean new one. So that was one thing that was very upsetting to see nurses do, pick up that same dirty used alcohol pad and reuse it. So I do want y'all to know what the CLABSI bundles of care are. Central line associated bloodstream infections. There's bundles of care. If we do these cares, we prevent the infections. Wash your hands, use chlorhexidine, scrub the hub, sing happy birthday. Full drapes. You saw pictures of them. They had that when they were putting that central line in the video. You just saw that they had drapes that went from the head to toe. Everybody had masks, gowns, hair bonnets on. They used timeout, checklist, transparent dressings changed every 7. But if you go in your room and you see your dressing is unocclusive, well, germs are just marching straight into the bloodstream. So you have to do something about it and quickly change that central line dressing. The clotting bundles, you need to know those. How, somebody's got an indwelling urinary catheter. How do I prevent a urinary tract infection related to the catheter? Hand hygiene, barriers, daily meatal care. Don't have kinks or dependent loops in your Foley catheter. Don't let the Foley bag lay on the floor. Only insert a Foley if you're trained. So here's a practice question. The nurse admits a patient that's 100 kilograms with sepsis and hypotension and implements the 1 hour sepsis bundles. Which intervention is implemented? They're 100 kilograms. So we know that if you have somebody that's hypotensive with sepsis, we take their weight in kilograms, multiply it by 30. So 30 times 100, that's going to be 3,000 milliliters. So this patient needs 3 liters of fluid bolus. All right, that's from the Surviving Sepsis Campaign Sepsis Bundles. All right, here's the patient in septic shock. Which medicine should we give? The norepinephrine, the Lasix, the dobutamine, the milrinone, or the nitroprusside? So if they're in septic shock, that means their SBR is low. They need a vasopressor. Let's use the norepinephrine. All right, let's see if the patient's on a infusion of that norepinephrine, and now we look at their hemodynamics. What does the nurse do? All right, cardiac output is normal. Well, sometimes we see that in septic shock. Their MAP is low. Their SVR low. Pulmonary capillary wedge pressure low. So what do we need to do? We need to increase that norepinephrine drip because we need to get that MAP up to 65. That SVR needs to be up greater than 900. Look, so we need to go up on that rate. The patient has sepsis and they're hypotensive, and the nurse is given orders to start a norepinephrine drip. And they got an 18 gauge catheter. So what should the nurse do? Do we clarify the order? Do we call for a central line and go, no, I'm not putting that through a peripheral line? Or go ahead and hang it through the peripheral line? Or say, nope, never going to give norepinephrine through a peripheral line, so I'm going to give it intraosseously. So the answer is yes, I can give it through the peripheral line, but I know I want a central line because it's much safer, because if it infiltrates in this peripheral line, they may have to they may lose their extremity. So another thing is the test questions. If you're given big, long, drawn out test questions, just what we're trying to see is, can you notice the cues you need to notice to make a decision? So like in a stem of a question, you go, okay, this guy's 70 years old, he weighs 66 kilograms. All right, he's in the ED, we had blood cultures, we've got 2 antibiotics given, he's hypotensive, his lactate is sky high, he's gotten 2 liters of fluid bolus. So after the bolus, we got a bedside ultrasound, and we see ID collapse, and the stroke volume was only 14% of what it should be. So what should we do? So it looks like, let's try giving them another bolus. They're not where we are. That first bolus that we give is just for starters. I would say give this patient another bolus. Give them another bolus and see if we can get that stroke volume up to like 50%. Okay, let's get it up. Because remember, you may give 8 liters in the first 24 hours. So that 30 mils per kilogram is just for starters. So these are just kind of test taking questions that you think to yourself, and what kind of questions might, what will the nurse do, where you have to make a decision or select all the things that apply for all the things that we do for this patient in the plan of care, or what will you do first? Now it's a priority. You're going to do all these things, but what will you do first? I do have this link for the Faces of Sepsis. I recommend that y'all go to it. It's on our page, just to look at a few sepsis stories by different people. And you'll need to be able to make a plan of care. I do have the plan of care, a link to it from our page, so you can look and see a typical plan of care for a sepsis patient. I do recommend y'all consider joining the Sepsis Alliance. Y'all can get lifetime of CEUs at this site for free. All you have to do is sign up. So just know that people over the age of 65 are at risk. People with compromised immune systems are at risk for developing sepsis, and people who have recurrent infections are at risk for sepsis. And then also know that, what are we going to do for these people that if they are an ICU survivor, we're going to think about post-sepsis syndrome interventions and post-ICU syndrome interventions. We're going to try to avoid benzodiazepines. We're going to we want to try to mobilize our patient. We want to get them out of bed as soon as possible because that will help with delirium. And we will do that CAM ICU daily. I want y'all to try to go do that next time in clinical. And just remember, bolus, bolus, bolus. You may have several boluses before you start with the vasopressors. This is dedicated to Desmond Silva, a frontline hero who got a COVID-related infection. And join me, please, all of you, as you go out there and start your careers in being a sepsis warrior. It's going to be on every unit in every clinic. You will all see sepsis. Thank you so much for being here. I'll stay behind if anybody needs anything from me, any questions, and if not, thanks for showing up.
Dr. Uddo?
Yep. Thank you. Thank you. Any questions? All right, then. I'm going to stop the recording, and I'll see y'all next time.
Recording stopped.